Hi all, welcome to Raaonline. Today we are going to deal with one interesting clinical disease which can have lot of systemic manifestation that can be an anesthesiologist's nightmare. That is nothing but obesity. We all think that obesity is a disease of harmonization. But here in this image you can see, which is commonly known as Venus of Willendorf. This was a statue which was found in Australia in 1908. If you look at this statue, you can see a squared body, bulbous contour, pendulous breast, and you can see a prominent belly. This statue was dating back around 20,000 years. So, this statue was ideally considered to be an icon of fertility or mother goddess. So, obesity in those age was actually considered to be good. But what has happened now? It has become ugly. From there it has moved to bad. Why I say so? This is a portrait of man called Daniel Lambert, who was an animal breeder and a goalkeeper for football. And during this time, 1970 to 1809, he was the fattest man in England. What is so specific about this man? Because his portrait was kept in the Ontario Museum as one of the gross human anomaly. But what did this guy do? Use this obesity as a hallmark for getting money. He used to go to a lot of places and display his human anomaly and gain money. And another important history which is attached to obesity is called Quetelet's index, through which we calculate the body mass index. This was named after Alphonse Quetelet, who is a Belgian astronomer turned statistician. He was the one who used the formula where you divide the weight by the height squared. This was a stamp which was released by Belgian government in honor of the Quetelet index. He actually devised this to see whether the French and the Scottish army people lie within the normal range. Later this index was used to classify obesity. Now coming to the definition. It is nothing but abnormal growth of adipose tissue due to enlargement of fat cell, which is hypertrophic obesity, or increase in number of fat cell, which is called hyperplastic obesity. Or it can be a combination of both. Two things are here. One is enlargement of the cell, another is increase in number of the cells. It can be also said that abnormal increase in the proportion of fat cells characterized by adipocyte hypertrophy. This is the definition of obesity. With regard to body mass index, how will you define obesity? The normal body mass index is between 18.25 to 25. That is normal range. You call underweight when the body mass index is less than 18.5. Before obesity, there is a stage called overweight or pre-obese, in which your body mass index is between 25 to 30. Now coming to the obesity, which is classically defined as body mass index greater than 30. There are three classes in obesity. Class 1 is 30 to 35 body mass index, and class 2 is between 35 to 40, and class 3, which is morbid obesity, here your body mass index is greater than 40, or you can say it is between 40 to 45. Few textbooks comes with two other definition, which is super obesity, where your body mass index is between 45 to 50, and super obesity, where your body mass index is greater than 50. This is the definition of obesity based on body mass index. Now coming to classification. As I said earlier in the definition, there is hypertrophic as well as hyperplastic. In hyperplasia, there is increase in number of fat cells. Just the fat cell increases in number, but the size is not altered. But in hypertrophy, the size increases and the fat cells become pathological. This is more harmful. There is increase in size, but your fat cells are totally dysplastic. If you look at hyperplasia, the number of fat cells is increased, your free fatty acid release is decreased, adiponectin is increased. Most important thing is your pro-inflammatory cytokine is decreased. Therefore, your immune cell requirement is decreased. There is decreased hypoxia and fibrosis, and the insulin sensitivity is maintained. But in hypertrophy, your cell size is increased, your free fatty acid release is increased, your adiponectin is coming down, pro-inflammatory cytokine is increased, which might lead to lot of disease condition. Your immune cell requirement is increased, hypoxia sets in, fibrosis increased, and most important thing is there is insulin resistance. Now coming to another classification, which is central and peripheral. The central obesity is also called as android obesity. It is apple shaped and it is called upper body obesity, above the waist. Here you can see the obesity is mostly above the waist and it is called visceral fat obesity. Coming to peripheral obesity, it is called gynecoid because of the shape, and it is called pear-shaped obesity. Here the obesity is on the lower body. It is not upper body. It is lower body and it is mostly subcutaneous fat. The central obesity is dangerous and peripheral obesity is less dangerous. Now coming to another classification, subcutaneous or visceral obesity. In subcutaneous, the fats get deposited in the subcutaneous part, that is subcutaneous obesity. In visceral obesity, the fat get deposited in the visceral part and it slowly expands. So, it affects the visceral organ. This is visceral obesity. In subcutaneous obesity, there will be anti-inflammatory adipokines. So, it gives protection against inflammation, diabetes mellitus and cardiovascular disease. But in visceral obesity, there is increased pro-inflammatory adipokinases, and what happens is there is increased diabetes mellitus, metabolic syndrome and cardiovascular disease. Now coming to some other measurements of obesity. The first and foremost is the waist circumference, which is measured between the inferior margin of the 12th rib and the superior border of the iliac crest. Midway, you have to measure the waist. Normally, some people measure at the level of umbilicus. When the waist circumference is greater than 94 in men and greater than 80 centimeter in women, that means there is a risk of cardiovascular disease. The risk is substantially increased when the waist circumference is greater than 102 centimeter in men and greater than 88 centimeter in women. Up to body mass index between 25 to 35, incorporating waist circumference will provide additional information. But if your body mass index is going to be greater than 35, already the patient is morbidly obese. Here, the waist circumference cannot give any additional information. Now coming to another important measurement, which is called the neck circumference. Usually the neck circumference is measured just below the cricoid cartilage. And whenever your neck circumference is going to be high, it is always a form of upper obesity. The neck circumference is usually done to monitor weight loss and see whether there is any risk of development of obstructive sleep apnea. When the neck circumference is greater than 43 centimeter or 17 inches, it is going to be associated with development of obstructive sleep apnea. If the neck circumference is greater than 60 centimeter, it is associated with difficult laryngoscopy, difficult bag mask ventilation, and more importantly, quicker desaturation. Coming to few other definition, what is total body weight? This is nothing but actual weight of the patient. It includes protein, your intracellular and extracellular water, bone mass, and the fat content, which is going to be very big with obese patient. Coming to ideal body weight, this is nothing but the ratio of your lean body mass to your fat content. It varies with age and usually approximated to the function of height and sex. It is calculated by the formula height in centimeter minus x, where x is going to be 105 in females and 100 in male. For example, if you take some 150 centimeter female, your body weight, ideal body weight will be roughly around 45 kgs. If you take 170 centimeter male, your ideal body weight will be somewhere around 70 kg. That is how you calculate an ideal body weight. Coming to lean body weight, here the patient fat is excluded. Okay, the fat part is removed to calculate the lean body weight. There are many complex formula for calculating lean body weight, but the most commonly used is by Jenmaston, which is commonly followed. Regardless of the total body weight, lean body weight never exceeds 100 kg in men and 70 kg in women. Now coming to one more variable, which is called the adjusted body weight. Here we assume that obese individual have increased lean body mass and increased volume of distribution. It is calculated by adding 40%. So it is calculated by ideal body weight plus 0.4 into total body weight in kilogram minus ideal body weight. This is how you calculate the adjusted body weight. So this various weight parameters we use for drug dosing. Why you do that? Because here the obese patient is going to have lot of fat cells. Although the lipophilic drugs have large volume of distribution, here the change in volume of distribution is more drug specific. So depending on the weight, you can't give a generalized dosing. Another important thing is you can dose the anesthetic agents to the end effect. For example, if you give an intravenous agent, you can use as loss of iris reflex as the end point. Similarly, with muscle relaxant, you can use a nerve stimulator or a clinical relief of pain for opioids. For most anesthetic agent, dosing to total body weight is rarely appropriate and increases the chance of drug overdosage. So don't go with total body weight. You should go with lean or adjusted body weight. Usually these are only used for calculating the anesthetic drug dose. Either you have to go with lean or adjusted body weight. Now coming to pathophysiology of obesity, it is going to be excess fat, increased oxidative stress, and which might lead to increased appetite and food consumption and down regulation of calorie utilization. So more calorie will be available. Apart from that, you have release of cholecystokinin, glucagon, ghrelin, which can increase your appetite and induce satiety. And you have hyperlipidemia, increase in adipocytes and cytokine release. Another important thing is insulin resistance, which gives a decreased feeling of satiety, so you will have more food intake. Here you can see the fat cell increasing in number as well as in size, and it can deposit in the subcutaneous tissue, which is less harmful, but it can go into the viscera, which can be more harmful, or it can deposit into the vascular tissues, which can lead to atherosclerosis. Depending upon where it gets deposited, you have differences in clinical outcome, complications, prognosis, risk factor, your life quality, and your therapeutic options. At the cellular level, the fat cell is altered, macrophage M1, which plays a great role in obesity, and there is liposomes alteration. At the receptor level, there is going to be increased free fatty acid, insulin resistance is there, renin-angiotensin system activity, increased inflammation, increased sympathetic nervous system activation, and increased level of insulin. So you have dyslipidemia, which can lead to coronary artery disease, diabetes, obstructive sleep apnea, which can lead to systemic as well as pulmonary hypertension. Finally, heart failure sets in. Now coming to various obesity related diseases. You can have major depression, bipolar disorder, Alzheimer's disease, particularly dementia, post-operative cognitive dysfunction. With regard to heart, you can have hypertension, heart failure, ischemic heart disease, prone for MI, and arrhythmias, particularly atrial fibrillation. At the metabolic level, you have diabetes mellitus, dyslipidemia, and there will be an hypercoagulable state which can lead to ischemic stroke, myocardial infarction, deep vein thrombosis, and pulmonary embolism. And you can develop cirrhosis in liver. With renal, you can have type 2 diabetes mellitus as well as hypertension. Obstructive sleep apnea can lead to lot of complications in the post-operative period like desaturation, respiratory failure, more reintubation, cardiac adverse event, and again shifting back into intensive care unit. And hypoventilation, obesity hypoventilation syndrome can lead to carpulmonary, post-operative respiratory or heart failure, prolonged intubation, and again ICU transfer. You have a severely compromised lung function, asthma can develop, gastroesophageal reflux, and not to forget osteoarthritis and gout. These are all various obesity related disorders. We will look at the three major organ system: cardiovascular, respiratory, and the renal system. Coming to heart failure, here there is fat deposited to the cardiomyocytes, which can alter your heart rate as well as your contractility. There will be tachycardia but altered contractility. And this altered metabolic profile can lead to increased hyperglycemia, diabetes mellitus, which have traditional risk factors. There is hyperlipidemia, hypertension, and diabetes mellitus. And your autonomic dysfunction can also alter your heart rate, and they can be decreased peripheral vascular resistance, which can play a big role in your ventricular filling pressure, and your mechanical effect of abdominal fat mass on the thoracic cavity can cause hypoxia, and your obstructive sleep apnea and obesity hyperventilation syndrome can increase your pulmonary artery pressure, which has an back pressure on the cardiovascular system, and increased blood volume and increased renin-angiotensin system can have bad effects on the heart. Finally, through natriuretic peptide modulation through altered lipolysis also can affect your cardiac function. Now coming to the most important system which is affected in obesity, respiratory system. Before going into the effect on the respiratory system, a few definitions. Atmospheric pressure is nothing but the pressure in the atmosphere. Alveoli, here the pressure inside the alveoli, and pleural pressure is outside the alveoli. Okay, you have to understand that. And what is transpulmonary pressure? Transpulmonary pressure is the difference between alveolar pressure and the pleural pressure. That is transpulmonary pressure. The second pressure which you should know is transthoracic pressure, which is the difference between the pleural pressure and the atmospheric pressure. But what is more important is the transthoraco-pulmonary pressure, which is the difference between the alveolar pressure and the atmospheric pressure. This pressure is going to be altered in obesity. Normally, the diving pressure is going to be your Plato pressure, and what is going to be the transpulmonary driving pressure? That is the difference between the alveolar and the pleural pressure. Here it is going to be the difference between the plateau pressure, which is the driving pressure, minus your transthoracic driving pressure. This transthoracic driving pressure is the one which is going to be altered by your abdominal pressure as well as the fat which is surrounding the lung. If you take a look at the lung volume, your functional residual capacity is altered, your expiratory reserve volume is altered, but the residual volume is same. So, the lung volume is decreased. If you compare anesthetized with non-anesthetized, you can see the lung volume in obese is almost 1/3 reduced in awake, and this is almost 50% reduced with obese anesthetized. And if you look at the functional residual capacity, you can see the curve coming down with awake, and it is almost reduced 2/3 with anesthetized. Your functional residual capacity is so much reduced that patient is prone for hypoxia even with a slight insult. Now, coming into airway diameter. This is the normal lumen of the bronchi, and this is a smooth muscle arrangement in normal bronchi. Here you can see on zooming it further, the smooth muscles are arranged properly with gaps in between, which maintains the patency of the bronchi. Now, with fat deposits, once fats getting deposited, here the lumen is also altered, and not only that, the smooth muscle function is also altered. If you zoom in properly, here you can see, as you zoom in, the smooth muscles which was present previously is altered and the contraction is lost. Therefore, the patency will be altered. Here you can see a rugged thing which reduces the lumen of the bronchi due to fat deposit. If you look at the bronchi before and after the fat deposit, this is the normal lumen and you can see the smooth muscle arrangement here. In obesity, you can see the luminal narrowing due to fat deposits, and here you can see the smooth muscles getting altered. And here you can see the narrowing of the lumen with the different. Here you can see a rounded lumen. Now coming to the compliance, this is the normal air movement. Air comes in and goes out and the lung expands nicely. With fat deposits on all sides, you can see the air movement is reduced and lung is in a closed cavity. So, the compliance is altered. For a little bit volume, the pressure increases drastically. So, the airflow will be limited. That is very important, and the compliance in obesity in respiratory system is drastically reduced. Here you can see the compliance. Lung in a constricted space, it has to expand and come down, which will affect the compliance very badly. Normally, there will be a good lung compliance. In obesity, because of surrounding fat, the lung compliance is reduced. To summarize what obesity does to the respiratory system, there is going to be decreased lung volume and increased work of breathing, which is going to alter your respiratory muscle performance. Your tidal volume is reduced. By reducing your tidal volume, you are going to increase your carbon dioxide and lower your oxygenation, which leads to hypoxia. To compensate for increased carbon dioxide, your bicarbonate goes up. Another important thing is there is increased carbon dioxide production too, which increases your hypercarbia, and your leptin resistance causes reduced respiratory dive. There is reduced arousal, and this can happen with altered neurotransmitter which comes from hypoxia also. Another important thing is disordered breathing pattern can cause upper airway obstruction and hypoventilation, which again leads to hypoxia and hypercarbia. And most important thing is hypoxia and hypercarbia always increases your pulmonary vascular resistance. On the mechanical side, there is going to be reduction of lung volume, obstruction of the upper airway, fat infiltration in the neck, holding mask will be difficult, and your diaphragm is pushed up, so the compliance is altered, and there is going to be abnormal upper airway neuromechanical control.